work that we do there, and you know, just what that kind of looks like. And I guess a little bit more about my background is that I'm actually new to working with psychosis. 2 years ago, I moved up here from Boston, where I was basically splitting time over the years between Mass General and the VA. And so most of my career is really focused on providing CBT to individuals with PTSD, the range of anxiety disorders, complicated grief. And I was always in a hospital system before moving to Maine. So this opportunity came up to kind of go back and join the hospital system here. And even though it's kind of a new area for me, it felt like a, you know, it was worth the risk to join this program and see how it goes. And it's been great. It's a really great program to be a part of. So should I open up the slides? Is that okay?
Yeah, thank you.
I'm gonna try to make the screen so I can see most people. Sorry, hang on a second. Okay.
And do you want to go to slide?
Yeah. Okay. Everybody can see that okay? Okay. So the plan is for me to talk about first episode psychosis, and with a particular focus on the intervention techniques that I think that everyone here would probably be most interested in hearing about. This particular program, so PIER stands for Portland Identification and Early Referral Program. There are a number of PIER programs or similar programs across the country, which I'll tell you a little bit more about in a few minutes. But it's a multidisciplinary program, and a more of kind of an intensive program. So it's not just therapy that's provided, and I'll describe more, but what I was planning on focusing on after giving a kind of a broad overview is to tell you mostly about the individual therapy and the family-based work that we do in this program. And which is also kind of these are like considered like the kind of gold standard treatment programs and treatment techniques for individuals and families going through first episode psychosis. So this is kind of like an outline of what I was planning to talk about today. So one, to start to kind of talk about the public health approach to mental illness, including early intervention, talking about early warning symptoms and behaviors that would suggest the need for referral for treatment, and then discuss the treatment techniques utilized, and talk about the unique roles on the team and how they contribute to coordinated care. And as again, I was really planning on focusing more on like the individual and family-based therapy, but I'm going to kind of touch upon some of the other areas as well. And I have some additional slides if people want to hear more and there's time to talk about some of the other aspects of the program. So just to give I mean, I know everybody here knows about these things, but just to kind of give a little bit of a background and just some ways to think about psychosis. So, you know, we see this as occurring across multiple disorders. So of course we see this in schizophrenia, bipolar disorder, major depressive disorder, and kind of going down the list here. So far in the work that I've been doing in the program, it's, you know, we're tending to see mostly people with schizophrenia, bipolar depression, and substance use. Although what I think you also see a lot, especially in the age range that this program focuses on, is that the diagnosis is kind of unclear at this point, and there's a lot of assessment and kind of working with these individuals and families to really understand over time like what might be developing. But I would say oftentimes it doesn't feel kind of clear right away. So some of the risk factors for psychosis. So trauma is one of the most significant risk factors for developing psychosis. Abuse, bullying, socioeconomic factors, early disruption to relationships with primary caregivers. So these are all the things that can place someone at risk for the development of psychosis. Some other things to think about. So anyone can develop it. We talk about it being on a continuum, really on a kind of a spectrum, so that all of us can experience unusual things. And that it, that it, to kind of think about it, it's not like kind of present or absent, but that it can kind of be more on a kind of continuum, like thinking about it more on a continuum. Some things that can kind of contribute would be not sleeping for multiple days, drug use, medical conditions, genetics, and trauma. And certainly within the patient population at PIER, you're kind of seeing like really all of these factors. I think maybe most of you guys know that about 3 in 100 people develop psychosis. There's a high mortality rate for individuals with psychosis, about 24 times higher than the general population. And so really what we're kind of, understanding and seeing is that it's really that community education, appropriate referrals, and early intervention are really critical for working with people with psychosis and trying to help them reduce some of these, complications that they could experience as a result of psychosis. So factors that worsen psychosis, substance use, and certainly that's kind of highly problematic in this population. Longer periods of untreated psychosis. So this is called DUP, or duration of untreated psychosis. I'm going to talk a little bit more about that. And then these other kind of stressful experiences. So COVID has really been, and it's kind of an interesting, because my introduction into this field was like 6 weeks, pre-COVID, and then everything has been kind of, since COVID, working remotely and dealing with all of the stressors of this entire year. So that's just been kind of interesting to see how that's impacted the people that I've been working with. So early intervention has really become kind of a critical factor in thinking about how to successfully treat people with psychosis and first episode psychosis. So the longer time in untreated psychosis, or again, like the duration of untreated psychosis, leads to worse outcomes and kind of a poorer response to treatment. So to think about it as like, stage 1 versus stage 4 cancer, or immediate versus delayed treatment for a heart attack. So basically the earlier that we can intervene, the higher likelihood that someone will have, kind of better outcomes in terms of functioning and symptoms. So the World Health Organization recommends starting treatments within 3 to 4 months of a psychotic episode. But what I'll kind of show you is that really is, that's not happening. Essentially, that's very unlikely to occur, kind of currently. So in terms of what has kind of happened in Maine in terms of early psychosis treatment, so there's kind of been 2 iterations of the PIER program at Maine Med. And so the first was from 1999 to 2011, where there was support from, there was kind of like grant funding that supported this program. And Bill McFarland was running this program, was mostly focusing on more of the clinical high risk population. Started in Portland and then was in 6 sites across the country. So when that funding ended, there was, basically the program was like on hiatus for a couple of years until 2015, where they were able to restart it in partnership with the state of Maine. So where Maine provides a large amount of funding and support for this program to be run, with the idea that over time, trying to find ways for the program to be more self-sufficient. So when this restarted in 2015, the initial focus was on first episode psychosis, and then later added the clinical high risk for psychosis. So now kind of trying to address and treat anyone who's at any risk or has experienced a psychotic episode. And so also what you see really over the last like 10 years or so is this general progress in terms of providing early intervention for psychosis. So you can, this kind of just explains it. In 2008, you see about 2 states with, fewer programs, fewer clinicians, and fewer youths involved in care. to 2018, where most states have like a good number of CSC stands for Coordinated Specialty Care Programs, and I'll explain more about what that means, with 1,000 clinicians and about 10,000 youth. So you kind of, the kind of options for care, and I kind of think about this like almost from the bottom up here, starting with intensive treatment, and coordinated specialty care is, the PIER program is a coordinated specialty care program. So you kind of think that the idea is really going from the almost like the, I guess visually here, like the bottom up, where oftentimes after someone's had a psychotic episode or has had some kind of clinical high risk for psychosis, they're engaging in some kind of intensive treatment program. A lot of our referrals come straight from the inpatient units around in Maine, so that they engage in a more intensive treatment program initially, and then it kind of step down from there to more general outpatient services, ideally evidence-based and measurement guided. And then even maybe from there, where they're just being followed in primary care after maybe they've reached a point of stability. So in terms of coordinated specialty care, so this is, when you talk about coordinated specialty care, this is basically what it means. And this is also on the PIER program has actually a really extensive, a really good website, and this is on there too. And it just, and I talk about this with patients as well, just so that they understand, like when we're talking about what the PIER program is, this is what we're kind of talking about. So, you know, kind of just starting with individual counseling, basically when they're kind of participating in this level of treatment, their idea is to be participating in all areas, ideally, of this circle. So starting with individual counseling, that would be someone like myself or other clinicians where you're focusing on evidence-based treatment for psychosis. So the treatment that everybody's trained in on this team is cognitive behavioral therapy for psychosis. But because there's such an overlap with other, you know, other disorders and other symptoms, you might be doing, you know, CBT for anxiety, potentially doing some trauma work, or working on their depression. So it could be even like a maybe more of a broader based CBT. But the idea is that the treatment is kind of following the kind of an evidence-based treatment model. And then kind of going clockwise here to care coordination. So our program and any coordinated specialty care program would also have a care coordinator. So they could be helping with appointments with the psychiatrist, main care applications, disability applications, you know, any other kind of financial struggles or, you know, just any kind of coordination that's needed. And our care coordinator is amazing. And she has really her kind of hand in every single family that's a part of the program, is just doing so much work to try to help, you know, eliminate any kind of additional barriers that exist to help, you know, get them the care that they need. And then psychiatric consultation and medication. So that's the psychiatrist. Any intake that we do in this program is both with one of the clinicians and the psychiatrist. We're kind of meeting them at the same time and going through an intake together. There's also vocational support. So there's an education and employment specialist that works with everyone in the program, as long as they're wanting to work with this person to either talk about you know, school accommodations, or, you know, thinking about where, like, what would be some good places to work, or what would be some of their work goals. So it's kind of nice, I think, because there's so many needs within each individual and family that it's not all on like the individual therapist to basically be doing all these things where then you can never really get to the therapy. There's peer support. And so in Maine, the peer support model that's used across the state is called intentional peer support. This is a new area for me. I didn't really know much about peer support before joining this program. So peer support specialists are people that have their own lived experience with the mental health system. And they're not really providing therapy, and actually they're very much a core part of the team, but they don't, they kind of say like nothing about us without us. So they don't really kind of know a lot about what's bringing somebody in, what's going on for them diagnostically, unless they hear it from the person themselves. And then the last component is multifamily group and family support. So this is a family-based program. And it's not 100% of the time I would say that the family's involved, but that's always really the goal, is to try to have parents or siblings or whoever's in their lives participating in this program as well. So multifamily group would be one way that they participate, but then also on occasion, just depending on the circumstances, people would also get like kind of single family support, or just kind of individualized more family support, just one-on-one with a clinician. So when you think about coordinated specialty care, this is the model. This is kind of everybody that's involved in the program and everybody involved working with each family to try to, kind of mitigate, I guess, the effects of psychosis or high risk for psychosis on the individual as well as the family. Does anybody have any questions so far? Or I don't know, I guess I just leave time at the end for questions, but I guess as I'm going, please just, I guess, put something in the chat or raise your hand. If I see it, I'll try to stop. All good?
Yeah, that's true. We can use the chat box, so feel free to add questions in there. I'll monitor.
Okay.
Thank you.
Yeah. So this is the program now, as of now. So it's the focus is ages 14 to 26 within 1 year of a first episode of psychosis. Now, especially for years, they've been working on implementing telehealth because of like the way that Maine is, and that, to be able to increase the catchment area. But now there are no restrictions because we can see anybody across the state. And really, I think we always could, as long as somebody could get to Portland. But now it really actually, there's like a further barrier that's eliminated because we're doing, it's all telehealth at this point. So Sarah Lynch, program manager, I think is like a confusing term to me, but essentially she's a program director and she's been working in psychosis for 20 years. And she's fantastic. And so, and then so there's Sarah, myself, and several other individual clinicians. We have one psychiatrist and then one case manager, kind of one person, per area on that kind of coordinated specialty care circle. All of the things here in red are so all that goes into this work and going into this kind of model, most of it is not actually reimbursable, or it's not really something that you can kind of charge for. So all of the case management, the support employment, some of the family work and peer support is not typically something that's covered. In addition to that, we have twice a week multidisciplinary team meetings. There's a lot of community engagement. You don't have a large caseload because one family or one person can take up several hours a week. And so a lot kind of goes in, but it's not necessarily something that's, this is why the kind of state is there to support, because it's not necessarily something that is able to kind of be sustainable on its own. So just to give a sense of some of the outcomes, this program, similar to PSM, they collect data. We do a lot of assessments every 3 months. This is just a little bit of some information on how things tend to look over the course of treatment. So the HUDAS, I don't know if anyone's familiar with it, but basically it's just a measure of like functioning ADLs. So you see that this improves over the course of time within the program. PIER is usually somewhere between a 1 to 2 year program. So I still think of it as like time limited treatment, although it's like that kind of time is extended. It's not that once they're in forever, but it's also that you can kind of see when you're working with some people that some people need that 1 to 2 years to really kind of get the benefit of the program. And then also just looking at, enrolled means enrolled in school, so enrolled or employed, that over the course of time, you're seeing a good number that are enrolled in school, but working kind of towards either, whether enrolled or employed over the course of time in the program. Another, one of the benefits of earlier intervention, which I didn't really kind of go into, I just said it's kind of critical, but there's, several reasons why it's critical. So one of them is reducing hospitalizations. We see that for those prior to PIER, the majority of patients coming in have been hospitalized at least once. And then over the course of, during their time in PIER, that rate of hospitalization goes way down. And I think, what I've kind of seen so far is that we might have people hospitalized kind of early on a couple of times, but then once they kind of get their footing, feel like they're kind of their treatment, kind of get into a kind of an established treatment and established medication regimen that, kind of rate of hospitalization is much lower. So just to kind of mention a little bit of, before just talking about the treatment that we do, I wanted to kind of talk a little bit about community outreach and referral and how we engage individuals and families in this program. So just kind of really just jumping in early psychosis, treatment delays are common, 1 to 3 years, 80% dropout within the first year of treatment. And as I was talking about, ideally with the duration of untreated psychosis being somewhere around 3 months from that first episode, this obviously doesn't map on with that very well. So the work is to really try to reduce how long people are out there without without treatment, and get people to also kind of engage as early as possible. So these are just some of the strategies that this program employs to try to engage early. There's like all sorts of networks they've created with families that have already been a part of the program, young people that have been a part of the program, other peers, speakers bureaus, all these kind of different avenues to try to engage families and the young people in the program. This is why this is like a family-based program, because the family involvement is key, especially when the young adult is paranoid or really disorganized or just doesn't really have the insight that they really have any problems. And most of the time that's how we're kind of hooking people in, is through their family. We try to have as much like kind of they call them like rapid access intakes, so as soon as possible, as soon as the referral comes in, to not have any delay, and having people come in and get evaluated, and have any kind of option for drop-in as well. It's obviously different now with Zoom and everything being remote, but as much as possible having that flexibility. And I would say, and this is kind of different for me, and this might be different for others, but there's so much flexibility with missed appointments where, to a point, you still have a limit where if someone's missing so much, they're not really participating in the program, that you're not going to continue. But I think much more so than ever before for me, where there's this flexibility of either trying to move an appointment from one time in the week to another time in the week, or, if they've missed for a couple of weeks, to, more try to kind of help them engage and not put it so much on them to be able to kind of organize enough to get there. So that you're trying to kind of have that follow-up and flexibility as much as possible, in a way within reason, until it kind of hits a point where it's like, it's not really going to change anything. So you're kind of trying to engage at multiple kind of levels here. So community engagement, family engagement, individual engagement, to try to maximize the likelihood that someone participates. So I wanted to just talk a little bit about cognitive behavioral therapy for psychosis. So I will say, I feel like most typical way that this seems to kind of happen is, so someone comes in for an intake, and the intake process, I think, takes about, really like probably like 4 weeks for, I think, an individual and family to feel like kind of settled, and they understand what PIER is about, and they understand what the program is going to kind of look like. And especially because on Zoom now, where it's, when someone comes into the program and we're in person, they can meet with multiple people in one meeting. Now it's a little bit more complicated to have that happen. So I would say, like, between like intake and orientation and talking about everything, somewhere around that 4-week mark, you're probably going to kind of start into CVTP. There have been people where that isn't the case, because they're just their symptoms are so severe that either we're kind of heading towards rehospitalization, or the medications aren't really on board enough to help them participate in cognitive behavioral therapy. But ideally, that's kind of what you're aiming for, is a kind of early start with CBT as much as you can. And the reasons for this is, people with psychosis, they want to and can play an active role in their treatment. They, even when they are continuing to have psychotic symptoms, these like specific interventions, it's not just about medication. These specific interventions can really help them relate to their symptoms differently, feel in better control over their symptoms, and feel less distress. And so that's what we kind of see with CVTP, is that it improves psychotic symptoms, it decreases distress. There's evidence that, just skip to the research support for a minute, CVTP is kind of been shown to be statistically stable, effective in treating hallucinations in particular, but then has like other, kind of more small to medium effect sizes, effects on delusions, and then general and negative symptoms. So we kind of see across the board, it tends to be an effective treatment, and I think it's also kind of seen in combination with all the other treatment kind of elements that are provided as part of this work. So these are the overarching goals, and they look pretty similar, I think, to any other overarching goals of like a CBT treatment. I think that, and this isn't unique to psychosis, but I think that this idea of adopting like a living with illness strategy is a little bit, to me, like different than what you might work on or approach with other disorders that you might be working with. You're never really going for cure, of course, but that, you're kind of looking at, most likely these psychotic symptoms are going to be with them in some form for a good part of their life. And so it's not to feel like, oh, I'm feeling better, that's it. Like, you're probably going to be just doing better, to kind of be able to embrace this idea that there may be an ebb and flow to symptoms, there may be an ebb and flow to distress as other things happen in their lives. It could kind of put them at higher risk for feeling more symptomatic. And so that it's kind of embracing that that's part of things. And at the same time, it doesn't mean that life, that they're not going to have a good life, so it's just kind of trying to balance that, adopting like the living with, and also that life can still be quite good and meaningful. The kind of other goals are, when symptoms are there, also not feeling so distressed by them, which then of course like helps. It's the idea, again, similar with other treatments, where you're feeling like you're in control of your symptoms, not the other way around. And that's a pretty common goal, I would say, for people doing CVTP, is feeling like I'm in control of my voices, I'm in control of my thoughts, so that even when I have a scary thought, it doesn't mean that it's true and that I have to kind of take it and run with it. I can kind of slow it down and try to look at it differently. And then also, overall improving day-to-day function, quality of life, and then relapse prevention. And relapse prevention in and of itself can be like a several-month process, where you're really working with someone to, just kind of like monitor and manage how to deal with, any kind of potential relapse, or, if a relapse occurs. So CVTP is more like a phase-based treatment. There are kind of session by session kind of guidelines, but I would say you're more looking at it from this kind of phased-based approach of, not like session 1, I do this, session 2, I do this, session 3, I do this. Like phase 1 could be a month or 2 of starting an intro to CVTP, but then you maybe get off track a little bit, or maybe there's some urgent issues that arise, and then you go back to the intro. So, I think you're kind of always keeping that frame, but there's some fluidity to it and some flexibility that's needed, so that you're kind of paying attention to where you are in the process, but that knowing that like every session may not exactly be like on target with like a strict CBT intervention. So engagement and intro is really, introducing that 3-component model of thoughts, feelings, and behaviors. And then with the engagement, it's a lot of psychoeducation about voices, about thoughts, how to manage them. You would also probably be involving family in some of these sessions. That you usually, when times are normal, there's a monthly workshop that is open to the community, as well as any new family members and individuals, and and any of the young participants. But now that's like online, so that's on the website where they can look at this workshop. It's in an hour, but that just helps with kind of engagement, and helps they hear about someone who has had their own experience with the program or with psychosis, and just to have a better understanding of what psychosis is. So that's kind of wrapped up in that engagement and intro phase of CVTP. The second phase, assessment and goal setting, this is on the assessment. We do assessments prior to, so I don't usually like kind of stop the intro in a way, or it feels like it kind of goes a little bit, off to the side here of like, let's do these assessments and let's kind of get back on track. So we do the assessments early, and then more focus on goal setting. And it's kind of a more involved treatment plan, where you're looking at like all the various areas that typically affect someone with psychosis. So it could be like psychotic symptoms themselves, depression and anxiety, social functioning, substance use, trauma history. So you kind of go through this whole list of things that could be problematic, and try to kind of put together about 3 goals specific to those areas that they're struggling with, and then, specific to CVTP. And as part of that, you also work on what's called like making sense of everything that's happened, where you really try to kind of help them kind of capture basically what led up to where they are now, what like kind of long-term problems that led up to where they are now, some of the more like the kind of precipitating problems like right before maybe their episode, or, like in those last couple of months before they came into the program, before they got hospitalized. And then, to like, what are the things that are kind of ongoing, kind of problematic areas for them. So it just kind of helps them look, and then also working on like underlying concerns, or basically kind of core beliefs. So the idea here with the goal setting is to really look at like, what are my problem areas? What are the areas that I really want to work on? And, how do I kind of put this all together in the context of my life? What are the things that have happened to me that have, kind of brought me to the point where I am now, in a way that's been problematic, but then also what are the things that are protective and help me, to then help me kind of go forward between, over the course of treatment, but also just helping them think about going forward in their lives. So that kind of, it starts to become like more active treatment. Then you kind of move into that, kind of phases 3 and 4, more, I would say like the active, aspects of CBT, where you're working on like, so approaching problems on the problem list. That's like that list I was just mentioning. You're kind of, going through and trying to work exactly, work more specifically on the things that are problematic to them, and working on cognitive restructuring, other behavioral interventions. There's like, I think some flexibility there, kind of depending on what's going on. And again, this phase of things could be, months, where you're just working on behavioral strategies, or some cognitive restructuring, or it kind of depends on what's going on. And then finally, relapse prevention. As I was saying, that could also be for an extended period, as you're helping somebody transition from kind of this active part of work to maybe hopefully being in a better place, to help them kind of stay as stable as possible. Right now I'm working with someone where we're in relapse prevention, and he typically struggles over the course of the winter. So we've just decided, like, let's keep this going and focus on relapse prevention over the winter, see how that goes, with the idea that likely like discharging in the spring, as long as they're feeling okay. But this is, so we'll just kind of be focusing on relapse prevention now for the next couple of months, unless like something kind of more active happens and, that we need to kind of actively address it. Sorry, I just want to look at the time. This is a session structure. I don't think this would probably be very surprising for anyone. in terms of what it looks like. So I just want to kind of briefly mention the family piece and some of the family work that's done. So, as I was saying, like this is a family-based program, and you really see that the families play a critical role. A lot of the times, especially because this is at the age range of 14 to 26, I think you're going to see, varying levels of wanting to participate, engaging, or having insight into their problems. So excuse me, the family's involvement is so important because they'll communicate to the team, what they're noticing. They can communicate back to the young person what they're noticing. You really can see a difference of like how much someone tends to participate, depending on how much the family's involved. So there's two kind of main ways the family participates in the program. So there's one is MultiFamily Group. And so, oh, sorry, I think that just closed as I was looking at a question. Sorry. Okay. Kate, do you want me to answer this now or no, wait till after? Okay. So the role of families. So there's two ways that families are tend to participate in the program. So one is MultiFamily Group. And MultiFamily Group is basically, as it sounds, like multiple family members attend to this group. So it's usually the young person and one parent or two parents, sometimes siblings join. The idea behind MultiFamily Group is, and I think there's a slide here on it, is kind of a couple, like several fold. So one is an evidence-based treatment. It's designed to help families and participants better understand mental illness and kind of working together towards recovery. It highlights the family's role in recovery, which is very important. And you tend to see better outcomes for clients and families when they're part of this group. So what kind of tends to occur with MultiFamily Group is that it fosters communication, both within the family as well as between other family members who are going through something similar, which helps reduce stigma, because a lot of times, families and these young people, they don't necessarily want to talk about what's going on or want to let others in on what's going on, or feel like other people can kind of understand. It helps prevent crisis, it helps adhere to treatment and reduces anxiety and arousal. What it looks like, the actual structure is where basically it's bi-weekly and every other week for an hour and a half. The beginning two groups are really kind of a get to know you. So the first one is like very more lighthearted, like everybody just kind of introducing themselves and kind of doing some icebreakers. And then the second group is what's called Share Your Story, where everybody goes around and there's kind of some guided questions. What brings you into the PIER program, or, what led up to you coming here? What helped, like what makes it harder for you? What gives you hope? And then the parents are asked questions in terms of, what can they hope to, what are their hopes for their PIER program? And what are their hopes for their loved one that's in this program? But what you're doing for the family is you're also trying to model, so often, and if any of you are, any of you who are parents, you may kind of relate to the fact that, as a parent, someone wants to say, well, like my child feels this, and this, or, really kind of they're talking about their child's experience. But what we're encouraging in MultiFamily Group is them talking about their own experience, and also like how they're affected by what's going on, and less so kind of talking for their kind of family member. So after you have those Share Your Story, kind of get to know you groups, then the group transitions into problem solving. And so basically there, everybody goes around and says like what's going well and what could be better. And you take that what could be better and you problem solve. And the entire, the idea is for the entire group to participate in it. So it helps so it helps with that kind of communication, because sometimes things are said that aren't necessarily said outside of the group. And then you're also kind of modeling how to try to make something better, how to try to fix something. We try to pick problems that are applicable to as many people there as possible. And it's, kind of breaking down goals into manageable steps, and making things more kind of functional. So it's kind of a nice and a different way for these families to be able to communicate with each other, again, both within the family as well as between other families. Sometimes though, this is not possible for a variety of reasons. Sometimes the young participant refuses to come, and either just the parents go, or we do some single family work kind of based on this model. There's sometimes, and just in terms of thinking of like specific examples, there are some families where there are so many barriers to even just participating in the program, where it might be hard for them to then participate in this group. So on occasion, we would just focus on trying to do this one-on-one, and ideally with like all members of the family. Sometimes just the parents are participating, especially if their young adult is not is kind of minimally like interested or engaged or wanting to participate in the program. This might be a way that we try to helping the parents kind of coach them to engage in the program. So that's kind of that's how like the family work tends to look in this program. And I know we're basically kind of out of time. So just some takeaways, and then I can try to answer some questions. So, the idea here is that without treatment, the psychotic disorders can have tragic effects, and treatment works. There are effective treatments out there, but, ideally really needing to be started as soon as possible. And also when treatments are comprehensive and coordinated. So this, the PIER program, it's an amazing program, and it's really, being able to watch some of these families go through the program and feel and be in a significantly better place than when they started has been really amazing to see in just less than a year of me being a part of this program. So the idea here is to try to make this more sustainable. As I was saying, as you showing from that earlier slide, that a lot of the work that goes into these kinds of programs are not not covered, and so the kind of the next steps in this work for this program is like figuring out sustainability and like funding that also kind of helps carry the program over the long term. So that is, in a nutshell, some of the work that I've been doing, and the PIER program, and some work with first episode psychosis. I feel like it's just kind of scratching the surface of this area, of this work in this field. But hopefully that just gives like a little bit of a flavor. Now, I look like there were, Kate, you had a question. So do you find that you're doing a lot of psychoeducation about psychosis in general? What is the level of insight into their diagnosis? Presumably they're aware that they have psychotic symptoms at the very least. Yeah, so there's a lot of psychoeducation. I think for the most part, the insight is pretty good. That I think more so than I would have necessarily expected. Or at least like the parents' insight is good, which helps try to, over time, improve the insight of the young person. But I would say for the most part, it's pretty good. And we're very kind of open about talking about diagnoses and talking about symptoms. And it's, I would say, like less so, the norm that you're seeing people who are so psychotic that they kind of can't participate in anything. And I think if that's the case, likely they'd be in the hospital, right? There's been a couple of times initially where the level of psychosis is still quite severe and the symptoms are quite high, but they're not, like, we're able to kind of keep them out of the hospital. But I would say it's a little bit more like education and support that's kind of my role initially sometimes, to get the psychiatrist to kind of get the right medication regimen on board, and then really like has allowed to move more into the CBT like once that's occurred. Does that help? Yeah. Okay. What are the most common types of clients, age, presenting concerns, other risk factors you're seeing in the high risk for psychosis category, and how are they identified or referred to PIER? I might just answer this question, I guess, backwards, in that the referrals come from, I mean, I would say like, so like the referrals I'm kind of thinking of coming from three places. One is like a parent or a family member hears about the program through their own research, and they're noticing some things, and then they're encouraging their loved one to consider the program. Then we also get referrals direct from the hospital, but that's less likely, I would say, like the clinical high risk, and more like the first episode psychosis, where they've already exhibited signs of psychosis. And then this is kind of that step down almost to this level of treatment as like the next step from hospitalization. And then on like current providers, where, someone's in treatment in the community with a provider, and they've heard about the program, or they're noticing things and are concerned, and then they reach out. I would say in terms of, and not having like, there's a lot of data that's collected, and I don't have the data off like the top of my head. So I'm kind of just speaking more anecdotally, but the common types of clients that we see, the age would probably be on the younger age of that kind of 14 to 26 spectrum for the clinical high risk. And then people who've had like ongoing and long-standing problems with depression or anxiety, trauma history, bullying, some of the things that those earlier slides said, that kind of rings true. And either they've maybe showed some signs of like, whether like some, kind of disorganized thinking, or, hearing things, but it's not really kind of at the point of really meeting criteria for like some kind of a psychotic episode, but that there's been some elements that are there that kind of point to this could kind of be getting worse, or the level of like drug use going up, or things like that would kind of put someone at higher risk for the development of psychosis. So that's kind of what we tend to see. Any other questions?
I do, Meredith.
Okay, go ahead. Go ahead. Someone else had a question.
Yeah.
Who else?
Oh, Julie.
Oh, okay. So do you want me to go, Julie?
Yes, please, Martha. Thank you.
I'm just curious about multi-generational. So like, is this the first kind of mental illness that's in the family, or are you finding that this is like families who've had a lot of this in their histories? Okay.
Yeah, so certainly there's like the genetic component of where it's part of like the family history. I would say even if psychosis isn't part of the family history, it's certainly there's a lot of problematic issues within the family, whether the other kind of functional issues, or the parents have their own level of their own struggles. That definitely is a factor, I think, in terms of how then these young people are also, what they're experiencing and how they're presenting.
Mm-hmm. Then I was wondering if then people don't keep coming in if there's a lot of dysfunction, right? There might be so hard to kind of be organized around one of the members' care.
Yeah, so that's why it is a family-based program, because we're trying to like engage everybody. Whether if they're needing their own help, that might be part of the work, is to get them their own help as well. Like if the family, the adult family members. But that it works so much better when everybody's involved and everybody's on the same page. And I've definitely seen it, not work as well when I can't get the parents to participate.
Yeah. Oh, interesting. Thank you.
Yeah.
Thank you for your presentation.
Yeah.
If the age range is 14 to 26, I'm just curious about why 26 is the upper limit. What does the research say about like first episode psychosis after that age? Or
Yeah, so there's actually another program at Maine Med called Resilience. And so that's why like this program is designed to really catch like with the early intervention, trying to catch, that first episode. And so working and within it's like first episode within a year within this age range. But then the other program, Resilience, is there is like overlap. It's like 18 and older. And that can be, that's like within 2 years of a first episode. So they kind of catch those that are more kind of adults. It's less of a family-based model. They are still doing CVTP, but they're more kind of in the adult program. So they're kind of catching those like kind of later on in life.
okay, yeah, I didn't know about that. And then I know in the past we're trying to rule out psychosis. And do you have anyone that consults with providers if they have questions or offer assistance on assessment prior to even a referral?
So like there is an outreach and referral coordinator whose job is just to do that essentially for the program. So their kind of referral process is really involved. So I would say like if there's a question where you would maybe be considering referring somebody, the outreach and referral coordinator would kind of walk you through that, and they do some assessments. But if it's more for consultation, but not like referral, I would probably still like utilize that person, because he would still, I think, feel like he kind of has his finger on the pulse of like the program, but also like who else is out there, and he would be able to make a referral, or you could just reach out to me and I could ask him. But they don't really do consultation. It's more like where they've done all this work for the referral, and then we might do like a 3-month trial with somebody, or we do the intake to make sure that they're a good fit. But it seems like most of the time, by the time they're getting to the intake, they seem like somewhat of a fit where we're at least gonna do like a 3-month trial to see if this program is like would work for them.
Mm-hmm.
So.
Okay.
And there are there is like this is a clinical research program. So there is a research arm to this program. And right now some research studies are getting started and others have kind of completed, but I think that would also be another avenue potentially for like assessment, to do like a skid, for some diagnostic clarity.
Great.
Yeah.
Sounds great. Thank you.
Yeah.
Anyone else? Oh, is there a question in the chat box remaining, or is that, okay, we got them all. We got them all.
Mm-hmm.
Well, Meredith, thank you so much. We are so lucky to have you as a contact too. So.
Yeah, no, it's good to see everybody and to kind of share what I've been working, doing for the last almost year now.
Oh, wow. Yeah. All right. Well, thank you, everybody. I hope you all have a wonderful Monday. The sun is shining now, so.
Yeah.
Thanks, Meredith.
So much.
Thank you guys. Good to see you guys.
Bye.
Thanks, Meredith. See you later.
Bye.